In this next section, we will discuss anti-tubercular and antifungal medications and when they should be used. In this section, we'll discuss antifungal and antitubercular medications. When it comes to treating tuberculosis, it's very important to remember that combination therapy is usually required, especially for multi-drug resistant strains. The primary drugs that are given for tuberculosis are the following: isoniazid, rifampin, pyrazinamide, and ethambutol. Streptomycin is an optional medication if a patient is allergic to one of those four medications. Tuberculosis infection occurs with direct contact from a person that is infected with active acid-fast bacilli in the sputum from one person to another, and that latent or primary tuberculosis infection causes a seroconversion or a skin test conversion 6 to 8 weeks after contact. During latent infection, a focus will form in the lung of the patient who has received the bug, and patients that develop healing will develop a latent infection that will not progress. 5% of patients will progress after 2 years to reactivation tuberculosis. Another 5% will progress within 5 years, and 10% of patients each year that have concurrent HIV infection will develop progression. In general, patients that develop tuberculosis seroconversion do not progress to miliary or reactivation tuberculosis. This is a gross pathology image that shows a caseating granuloma inside a patient's lung who developed tuberculosis. And this micrograph shows the acid-fast bacillus here that has been typed as Mycobacterium tuberculosis. Isoniazid, also known as isonicotine hydrazine or INH, is a primary medication that is used to treat tuberculosis. The way it works is by inhibiting mycolic acid synthesis in the mycobacterium, which impairs cell wall formation. It's considered to be bactericidal, and it's used for both treatment and prophylaxis in patients that have been exposed or infected with tuberculosis. There are many adverse effects to isoniazid. The most commonly known are that of it can cause an hepatitis-like syndrome with increased liver function tests. It can also cause a peripheral neuropathy that can be prevented by concomitant dosing with vitamin B6. INH can also cause a lupus-like syndrome that's more common in slow acetylators, or patients that have decreased activity of the N-acetyltransferase enzyme. Rifampin is another anti-tubercular medication that is actually being used more these days for indwelling catheter infections for simple bacterial infections as well. The way that it works is by inhibiting DNA-dependent RNA polymerase. It's considered to be bactericidal, and remember that it's a classic inducer of multiple cytochrome P450 enzymes. It's also used in other infections, like I said, for prophylaxis of meningococcal disease as well as H. flu meningitis. Rifampin does have multiple adverse effects. It's classically known to change secretions such as urine, sweat, and tears into a red-orange color. It can also cause hepatitis and a flu-like syndrome. It's also important to remember that rifampin is almost never given as monotherapy for any infection. Pyrazinamide is another anti-tuberculosis medication. The way that it works, it is converted to acidic metabolites which can inhibit the growth of mycobacteria, though we don't know exactly how it works. It's considered to be bacteriostatic only, and it does have some small adverse effects, including myalgia, hepatitis, and gout. Ethambutol is another commonly given anti-tubercular medication. It's only active against mycobacterial bugs. It's considered to be bactericidal, and the way that it works is by inhibiting the synthesis of arabinogalactan, which is a cell wall component of mycobacteria. The classic adverse effect of ethambutol is optic neuritis, which causes reddish-green color blindness and blurry vision. It's important to know that for the exam. Streptomycin, like I said, is a backup medication. If a patient is allergic to one of the other TB medications, they can take streptomycin, which is an aminoglycoside, as we talked about. It inhibits protein synthesis. It has similar adverse effects to other aminoglycosides that we've already talked about, including ototoxicity and nephrotoxicity. Some other antitubercular medications that are less commonly given are cycloserine, which is used to inhibit mycobacterial cell wall synthesis. It, however, has multiple side effects, including seizures. Capreomycin is also able to inhibit RNA synthesis, and it has similar side effects to aminoglycosides. These are much less commonly given than the other antitubercular medications we already talked about. For tuberculosis prophylaxis, patients that are high risk and they're exposed to tuberculosis, or patients that have a PPD conversion, those patients should take isoniazid for 6 months, or if they're allergic to isoniazid or they can't tolerate it, they can take rifampin and pyrazinamide for 2 months. This is for prophylaxis. These are patients that have not actually converted yet, or patients that have recently converted. Treatment regimens of tuberculosis involve patients that have a positive acid-fast culture. While the culture is running, the Centers for Disease Control recommend a 4-drug regimen for these patients until the sensitivity of the strain is known. And the standard 4-drug regimen is INH, rifampin, and pyrazinamide, plus either ethambutol or streptomycin. Once the sensitivity of this and the strain is known, it's possible to tailor back these 4-drug regimens into usually a 2 or 3-drug regimen. Prolonged TB treatment should include at least 2 drugs to which the strain is sensitive in vitro. Some common regimen are INH, rifampin, and pyrazinamide for 2 months, followed by INH and rifampin for an additional 4 months, or simply INH and rifampin for 9 months. Isoniazid, rifampin, and ethambutol are considered safe during pregnancy. Some other mycobacterial infections that you should know about include Mycobacterium avium intracellulare, and these are more common in immunocompromised patients. The drug of choice for these infections are azithromycin and clarithromycin. For Mycobacterium leprae, the cause of leprosy, dapsone plus or minus rifampin is used to treat these. Remember that dapsone is related to sulfa drugs and can cause hemolytic anemia in G6PD deficient patients. Let's talk about fungal infections and antifungal medications. Remember that fungal infections can be divided up into superficial infections and systemic infections. Obviously, systemic fungal infections are very serious. Fungal infections are often very difficult to treat, especially in patients that have immunocompromised status. And some invasive fungal infections can actually require immediate surgical intervention and are considered emergencies. As an example, we have rhinocerebral mucormycosis. In a patient that has diabetes, a nasal infection of mucormycosis can actually spread into the sinuses and into the brain and require surgical resection. In a case that a patient does have a systemic fungal infection, the medications that are available to those patients include multiple medications, including amphotericin B, which is considered the strongest usually, the quote-unquote azole family, including fluconazole and itraconazole, flucytosine, caspofungin, and griseofulvin. We'll talk about each of these. Amphotericin B is the prototypic systemic antifungal agent. The way that it works is by disrupting ergosterol in fungal membranes, and it causes pores to develop in the fungus and has a very broad spectrum in terms of killing fungi. Amphotericin B is the drug of choice for severe infections caused by multiple fungi, including Aspergillus, Candida, Crypto, Histo, Mucor, and Sporothrix. Fungi that have a low ergosterol content percentage will be resistant to amphotericin B. On the boards, you'll often see an X-ray or hear about an X-ray of a patient who has a lesion in the top of the lung, the upper lobe, that appears to be a ball shape or a sphere shape. That is Aspergillus until proven otherwise. Aspergillus infection usually involves the lung and usually the upper lobe of the lung. Candidiasis can be superficial or systemic. Here you can see the esophagus on growth pathology, and this is the inside of the stomach. And you can see here in the lower part of the esophagus, this patient has developed infection. And here on microscopy, you can see that the Candida infection has involved the area under the mucosa leading up all the way to the smooth muscle of the esophagus. This is lung pathologic image that shows cryptococcal involvement of the lung. This is severe cryptococcal pneumonia. And this is Cryptococcus neoformans that is seen in an India ink preparation. The crypto bugs appear white in the India ink background. And you can see here in a neutrophil the yeast of the Cryptococcus in a peripheral blood smear. Amphotericin B, which is used to treat all of these illnesses, has multiple adverse side effects. It's known as amphoterrible because of the side effects. It's a very difficult drug to tolerate. Patients that are receiving amphotericin B can develop fever, chills, rigors, and also hypotension because of histamine release. Patients that are receiving amphotericin B usually will be prophylaxed with NSAIDs and antihistamines before. The most important side effect, however, is renal tubule damage. Patients that take amphotericin B have a very high risk of developing renal failure. Amphotericin B has been formulated now in a liposomal formulation known as ambisome that has been designed to decrease renal toxicity, but it's very expensive. The azole family of antifungals are probably the most commonly used antifungals. They are fungicidals. They impair biosynthesis of ergosterol by inhibiting the fungal cytochrome P450. And they have very good activity against multiple different organisms, including Candida, Crypto, Blasto, Histo, Coccidioides, and ringworm fungi, including dermatophytes. The way that ketoconazole and other azoles work is by inhibiting the fungal cytochrome P450, which is responsible for converting lanosterol to ergosterol. And ergosterol is responsible for membrane synthesis. Therefore, if ketoconazole is present, then the fungus is not able to produce ergosterol for membrane synthesis. Remember that the azole family, because they inhibit the fungal P450, they're also able to inhibit the human P450. And remember that ketoconazole is the classic inhibitor of P450, and therefore it can cause other drug levels to increase, drugs that rely on the P450 enzyme for breakdown. Other adverse effects of the azoles include decreased synthesis of steroids, including androgens, and can cause gynecomastia in males because it inhibits the breakdown of estrogens. Flucytosine is another antifungal that is activated by cytosine deaminase, which is an enzyme inside the fungi, 5-fluorouracil. 5-fluorouracil, as you know, is a chemotherapy agent, but it also can be used to kill fungal cells. It is incorporated into fungal RNA and disrupts protein translation. Flucytosine is often used in coordination with amphotericin B for severe infections because it can penetrate the CSF. The major toxicity of flucytosine is to the bone marrow. It can cause bone marrow suppression, anemia, and neutropenia. Caspofungin is a newer class of antifungal medication. It belongs to the echinocandin family of antibiotics. It interferes with cell wall synthesis, and it's used for invasive aspergillosis and esophageal candidiasis. Generally pretty well tolerated. It can elevate liver enzymes, but it's much better tolerated than amphotericin B. Griseofulvin is another newer type of antifungal that disrupts fungal mitosis, and it's also able to concentrate in nail and newly formed skin. It's useful against dermatophytes, specifically those that cause tinea, ringworm, and athlete's foot. And often it's given to patients when they are resistant to topical treatment that have these types of infections. Griseofulvin generally is well tolerated. It does, however, cause a disulfiram-like reaction, meaning it can increase acetaldehyde concentration, which can cause flushing when patients drink alcohol along with griseofulvin. An important concept whenever we talk about antifungal medications is talk about Pneumocystis jirovecii, which was formerly known as Pneumocystis carinii. As you know, this is a unusual fungus that lacks ergosterol, formerly thought to be a parasite. This is an opportunistic bug that occurs often in patients that have AIDS or some other type of immunocompromised status. It's important to start patients on trimethoprim sulfamethoxazole or Bactrim when their CD4 count reaches below 200 per cubic millimeter. The infection of pneumocystis jirovecii can actually be treated with Bactrim as well. Other drugs that can be used include petamidine or atovaquone. Some localized fungal infections include dermatophytes, vaginal candidiasis, and oral candidiasis, and all of these are usually treated with topical antifungals. Here's a picture of tinea capitis. As you can see, this young boy has developed a fungal infection of his scalp. And this patient who has HIV has developed oral thrush or candidiasis of the tongue. Some topical antifungals include nystatin, which is very popular for oral and esophageal candidiasis, as well as intertrigo or a fungal infection of the skin. Some of the azole category of antifungals are also given topically, and as well as some newer antifungals such as butenofine. Nystatin works by binding to ergosterol, and it has a high toxicity, so therefore it cannot be used systemically. It's used as a powder topically on the skin or as a swish and swallow preparation. It's very effective against candida and is used for oral thrush and esophageal candidiasis, especially in HIV patients. This concludes our section on antitubercular and antifungal medications. Next, we'll move on to antivirals.